on this episode of 2036, the podcast.
I was taught when I was in medical school that heart disease, particularly coronary disease, is a man's disease. But I was seeing women in the clinic who were having chest pain. I was seeing women on the wards who were having heart attack, who were having myocardial infarction. And when I went to the literature, there was literally nothing about women. And then I went to the National Heart Institute, and I said, we really need to do something about this. Fortunately, I think I enrolled some people in my vision and asked the correct questions, and people began to look and realize that women are not just small men, and that there are major differences that we now know today in the pathophysiology, in the clinical presentation, in the diagnostic tests, in the management, and in the outcomes. But even though we've come a good way on that journey, we're far from complete. Women remain understudied, they remain underdiagnosed, they remain undertreated, and their outcomes are not as good as those for their male peers.
Welcome to 2036, the podcast, Season 3. I'm Ken Carter, professor of psychology at Emory University's Oxford College. Today, I'm here with Dr. Nanette K. Wenger. She's a professor of medicine in the Division of Cardiology at Emory University's School of Medicine and one of the country's most respected experts on coronary heart disease in women. She's earned dozens of awards in her celebrated career, but perhaps her greatest professional achievement has been changing the assumption that heart disease only affects men. In 2009, the women's health pioneer and renowned cardiologist received the Lifetime Achievement Award from the American College of Cardiology. Welcome to the podcast.
Thank you, Ken.
Now, you've had a really amazing career, so tell me what attracted you to medicine in the first place?
Well, in general, I love the sciences, but I also am very much a people person. And medicine seemed the ideal marriage between science and people.
And what about cardiology in particular? Because there's lots of different specialties in medicine. Was it something about cardiology that really pulled you towards it?
Well, during the years that I was in medical school, I was exposed to two phenomenal mentors, both cardiologists, Dr. Herman Blumgart and Dr. Louis Wolf at the Beth Israel Hospital in Boston. And what we did was to witness perhaps a pivotal point in cardiology where suddenly the findings in the laboratory became translatable to the bedside. And it was in part the golden age of cardiology. We were beginning to have techniques and instruments, and it was just the very, very first murmurings of cardiovascular surgery being done by our surgery colleagues, and the development of hosts of new medications that were based on biology.
Wow. So let's talk a little bit about that sort of golden age. Was medicine different then than it is now?
Medicine was very different. First, there was a much more individual and personal relationship between the physician and patient. And this virtually antedated Medicare or any type of insurance. So it was a personal relationship between the physician and the patient. There was relatively little administration involved. Those of us who stayed in academia essentially devised the teaching we were doing, devised the training we were doing, devised the research we were doing. But it was the beginning of major cardiovascular research. The National Institutes of Health had just started its clinical center, and there was a major cardiology presence there. The professional associations, the American Heart Association, American College of Cardiology, were beginning to reach out to the public. There was the beginning of learning about what put you at risk for heart disease rather than treating the end product. This was the beginning of the Framingham Heart Study, defining what we know as the traditional risk factors. And of course, if something puts you at risk, what do you do to mitigate that risk? And of course, this is now called preventive cardiology, but back then we called it risk reduction or risk modification. But there was a great deal of public information and public education. But the physician, indeed, was the trusted individual in the community and the respected individual in the community. Social media was non-existent. And we did some of the very primitive public education. I was in New York and Boston at the time, and in New York, there were signs in the subway which said, know your numbers, meaning what is the number of your blood pressure, what is the number of your cholesterol. So telling the patients something that they could go back and ask their physicians.
Now, early in your practice, you found yourself treating women with heart disease. What were some of the first indications that heart disease presents differently in women than in men?
Well, indeed, it was a predecessor to that because I was taught when I was in medical school that heart disease, particularly coronary disease, was a man's disease, and that women were protected premenopausally by their intrinsic hormones, and after menopause, everyone got menopausal hormone therapy, which was advertised as being good for everything between wrinkles and dementia and in between. And don't worry about it. Give the women the hormones, they have no disease. But I was seeing women in the clinic who were having chest pain. I was seeing women on the wards who were having heart attack, who were having myocardial infarction. And when I went to the literature, there was literally nothing about women. Everything that was done was studies in 60-kilogram middle-aged men, as a matter of fact, Caucasian men, and that was the model of disease, and it was supposed to be applicable to the universe. And I really started looking in the literature and found nothing. So being the curious person that I was, I went to the professional societies, to the Heart Association, to the American College of Cardiology, and said, we really need to do something about that, and was told it wasn't important. And then I went to the National Heart Institute. Lung and blood hadn't been incorporated. It was National Heart Institute then. And I said, we really need to do something about this. And it took several years, and they finally put a workshop together, and it was my privilege to co-chair that workshop. And 6 years later, it emerged into a conference. And basically what it did was to examine the data that were available about heart disease in women, including some of the symptom presentation, but most importantly, to identify knowledge gaps. And the summary of that paper was published in the New England Journal of Medicine, and I was privileged to be first author on the manuscript. And the New England Journal of Medicine editor at the time told me it was the first time that the terms coronary disease and women had appeared in the title of a manuscript in a major medical journal. But fortunately, I think I enrolled some people in my vision and asked the correct questions, and people began to look and realize that women are not just small men, and that there are major differences that we now know today in the pathophysiology, in the clinical presentation, in the diagnostic tests, in the management, and in the outcomes.
Yeah.
But even though we've come a good way on that journey, we're far from complete. Women remain understudied, they remain underdiagnosed, they remain undertreated, and their outcomes are not as good as those for their male peers.
Let's talk a little bit about that clinical presentation. Like, how is it different in women and men, coronary heart disease?
Well, let's talk about chest pain. And we have fairly elaborate chest pain guidelines. And when we look at the symptoms of a myocardial infarction, of a heart attack, about 80% of patients present with chest pain. And a fair number of them have associated symptoms, perhaps arm pain, perhaps neck and jaw pain, perhaps some nausea, etc. But those are not the presenting complaints. And that occurs both for men and for women. But perhaps, as I've said before, women are adjective-adverb people where men are noun-verb people. And the women will describe everything else they're feeling. They will describe a panoply of symptoms, from feeling tired, from feeling weak, from feeling neck, arm, jaw, back pain, epigastric discomfort, faintness, nausea, fatigue, etc. And sometimes the chest discomfort or chest pressure gets lost in that recitation. So that what I have trained my emergency room colleagues across the world to say is that acute symptoms in a woman, anywhere from the mandible to the umbilicus, think acute coronary syndrome. It may not be, but
rule it out.
But let it be in the evaluation you do initially. And of course, what's happened is that the emphasis on sex-gender specific medicine has changed outcomes, because beginning in probably about 2000, the annual mortality for women in this country began to decrease. It was always greater than that for men at cardiovascular mortality. And by about 2013, 2014, for the first time, fewer women than men died each year from heart disease. And I've said we are delighted to be in second place, and we hope to stay there.
So what is it physiologically that creates these differences?
I think it's more the descriptors. It's more the descriptors than anything else. And we don't have a uniform way. We don't have an agenda that will ask people to check off signs and symptoms.
Right.
But most of the men will come into the emergency room like this, saying, I'm having a heart attack.
Right.
And the women will just have the whole descriptor. It may be the difference in communication.
Now, in 2014, you helped found the Emory Women's Heart Center, which is described as dedicated to the screening, prevention, and treatment of heart disease in women. The center has a mostly female staff who have special training in the treatment of heart disease in women. Tell me a little bit about the center.
Well, it's not a physical center. It's a virtual center, so that we're not a brick-and-mortar operation. But all of the people who are involved with the Women's Heart Center have an interest in women and heart disease, are involved in the research studies, are involved in preventive cardiology. And as I've said, much of what we do, we work with a number of advanced practitioners, APPs and PAs, and do screening and do intervention, because there are many ostensibly healthy women who really can have better heart health if they're examined. And this is the area that we are emphasizing. And as I've said, we try to meet the women where they are. So we'll meet the women in the OB setting. We'll meet the women who have lupus or rheumatoid arthritis in the rheumatology clinic, introduce ourselves, and look at the cardiac risk factors, which we are more specialized in being able to treat and manage and explain to patients why this is important, in addition to the management for their primary disease. So we have many, many interests, and I think it's an important emphasis in Georgia, because in Georgia, maternal mortality is among the highest in the nation. And about a third of that mortality is cardiovascular, and much of that is preventable. So what we have to do is see that we have young women healthy as they come to pregnancy, follow them through the pregnancy, and if they have pregnancy outcomes, be sure that the adverse outcomes are followed up in the postpartum period. We've done something very exciting in Georgia, and I've paid multiple visits to the State House, and some of them seem to have culminated in favorable outcomes, because previously the women who were covered by Georgia Medicaid for a pregnancy were covered up to 6 weeks after delivery. And of course, that's just a drop in the bucket. Georgia Medicaid now covers women for 12 months.
Wow.
Which means we have the opportunity to detect the abnormalities, to work with the women to decrease their risk and improve their health, and working to improve the health of their families.
It sounds like that's had an incredible impact on people, and the center's been having an incredible impact as well.
We think it's important, and we have a number of interesting studies going on. For several years, actually, it was interrupted by the pandemic. We have the 10,000 Women study, and what we're doing is we're trying to meet 10,000 Black women where they are at houses of faith, at fairs, and what have you, and do screening for blood pressure, for cholesterol, et cetera. And most importantly, to see if there are abnormal values, that they are connected with a provider, and giving them the data that they can take to that provider. So it's information, it's education, it's screening, and we welcome the participation of any communities of Black women.
And so you're seeing them in multiple different settings.
Yes.
And so what impact do you hope this will have?
Well, again, impact is always data-driven. And we're beginning to look we've done a study on the first 1,000 women that we've done, and there is, as you might anticipate, a high prevalence of Black women who have elevated blood pressure, elevated glucose, elevated cholesterol. Most of them didn't know about it. So that, I think, is the first step. Now we're trying to do follow-up by phone to see if these people have contacted a healthcare provider and what has happened. You know, we had 2.5-year hiatus with the pandemic, and now we're beginning to regroup.
So in 2022, nearly 54% of all medical students in the U.S. medical schools were women. What do you think this percentage says about the future of healthcare?
Well, I think that what it means is that in a country that still has a physician shortage, that we are tapping half of the population that was untapped previously. And I think the percentage of women in medical schools has varied from about 48 to 54, but it's about half, and that's an appropriate representation. Now, what we have to do is to follow the career trajectories of these women and to see that they are given the opportunity to go into specialties that they choose, where they find privilege and pleasure in what they do in terms of taking care of patients. And we find that women are underrepresented in a number of specialties, and sadly cardiology is one of them. And one of the emphases of the women in cardiology at Emory is to work with medical students and with interns and residents, and we are trying to recruit women into cardiology. There's some very interesting studies that relate to provider, sex, gender, and patients. And the best studies are done where there's arbitrary assignment of a patient to a provider. And you see that in an intensive care unit or in an emergency department where they're just assigned arbitrarily. And there are really good data that show that women physicians have better outcomes, both women and men patients, than do their male peers. Small difference, but statistically significant. What do I think is the reason for it? I really don't think the women are better trained or any smarter, but I think women listen better. And listening to the patient and hearing what the patient tells you of what they perceive their problem to be often gives you so much more information, even prior to the laboratory data coming back, or helping you to properly order laboratory data. So I'm encouraging my male peers to listen more carefully.
Yeah. And do you think this will have an impact on things like research, drug development, patient care in many ways?
Well, the research has had some very important advances. In 2015, Congress, at long last, enacted the Research for All Act. And this mandated certain things in government-funded research. So it applied solely to government-funded research. And previously, it was always suggested, include women, include older people, include racial and ethnic minorities. This was a mandate by the GAO that women and minorities be included in research studies and that the plan be there. And if this doesn't happen, the study doesn't even progress to evaluation for funding. Very important. There was also provision for the basic scientists, that they know the provenance of the tissues and the cells that they were using for basic research. Because you would ask many of the basic scientists, where did these cells, where did this tissue come from? They weren't sure whether it came from male or female animals. And it now seems ludicrous that you use male cells or tissue to study a female disease. Now that provenance is required. But that's only government research. There is now, going through the Congress, as a matter of fact, it's now open for public comment, a law called the FDA Omnibus Act that relates to the Food and Drug Administration. Because so much research on drugs and devices is done by industry. And when industry has, for example, a new drug that they want to bring to market, they'll go to the FDA and say, if we study this drug in this many people for this long, and these are the outcomes that we get, what is the likelihood that this drug will be approved? And the FDA looks at the design, et cetera, and gives them some idea, gives them some advice, gives them some suggestions. And previously there were suggestions, be sure you include women, be sure you include elderly, et cetera. But they were recommendations. This Omnibus Act has teeth. So it will be a decade until this will change the way FDA interacts with industry. We have to see how the legislation is implemented, and then that will just be the beginning of new studies. But I think it is a very exciting advance for women in terms of their women's health.
I want to thank you so much for joining us on the podcast. It's been amazing talking with you.
This has been fun. It's an opportunity to discuss one of my favorite topics.
On the next episode of 2036, the podcast.
I think for climate change, we really need to figure out how can we grow food in a way that's much more environmentally friendly. So there's a lot of organic farming, but also can we use less fertilizers? Can we use less pesticides? I think those are interesting questions. And then what's the agricultural practice that is going to lead to less environmental pollution is what we're trying to get at.
Join us for a conversation with Eri Sakawa, the Winship Distinguished Research Professor of Environmental Sciences in the Department of Environmental Sciences and a Professor of Environmental Health at the Rollins School of Public Health. Listen on Apple Podcast, Spotify, or wherever you get your podcasts. To learn more about 2036, Emory's campaign to transform the future, visit 2036.emory.edu.